This module is on the practical aspects of visual evoked potentials, and so we'll talk about the patient, stimulation parameters, the montage for recording visual evoked potentials, the actual recording parameters, and the waveforms. Visual evoked potentials are a way for us to assess cortical visual function. Anything that stimulates the visual cortex can generate an evoked potential. And so anything that has a pattern, a change in contrast, a change in luminance will generate an evoked potential. And so within the research realm, there's many different ways to generate an evoked potential using different sorts of stimulation. However, within the clinical world, we have two standard types of stimulation, and these are chosen because normative values for these evoked potentials are well studied and well known. And so for us to use these evoked potentials, we have to stimulate in a very standardized way, and that allows us to measure against our norms. So the first type of clinical evoked potential stimulation is the flash stimulator. And so this is a bright light that is diffuse that activates the entire visual field. It activates the entire retina. The second type of visual evoked potential is generated by a pattern reversal. And so this is a difference in contrast between black and white squares that reverse black and white. They reverse their contrast every so often. And so that reversal creates an evoked potential. And this is used to look at the function, particularly of the macula, because it stimulates receptors in the fovea. And so the difference between the flash evoked potential and the pattern reversal evoked potential is in the extent to which the visual field is activated. So a flash evoked potential activates the entire visual field, whereas a pattern reversal activates specifically the foveal field. And so we'll talk about the importance of using these different ones and when they're used when we come to clinical correlations. Let's begin by talking about the patient. Flash VEPs are really valuable in patients who can't focus on a pattern stimulus or who have poor visual acuity. Flash visual evoked potentials can be recorded even while the patient is asleep, in coma, or during quiet relaxation. And so the flash stimulus is bright enough that it can go right through the eyelids. And so the patient can wear the goggles and be asleep, and a VEP would still be generated. The VEP waveform, however, is affected by deep sedation, but it's still useful for establishing whether a cortical visual response is present or absent. So the most useful thing for a VEP is to establish cortical function. And so for this reason, we don't often do monocular stimulation with the flash VEP. For a pattern reversal VEP, the patient is usually seated in a chair, paying attention to the screen. Cooperativity is absolutely essential, and the technologist must monitor the patient for loss of attention, or if the patient becomes distracted. They must monitor the patient for movement, for excessive eye blinking, and for eye rolling. Visual acuity is also really important and must be checked. A visual evoked potential is not obtainable if the visual acuity is poorer than 20/200, because this means that the patient cannot see the difference between the black and white checks, and so they can't do that contrast perception that's required to generate a VEP. If the acuity is poor, it would be ideal to correct the vision with glasses, and so patients should be encouraged to bring and to wear their glasses. If this is not doable, and the acuity is better than 20/200, then the test can be conducted, but this must be noted for the reader. The room lighting must be dimmed and the patient's eyes allowed to adapt to the darkness. This means sitting in the room for about 10 to 15 minutes to allow the eyes to become adjusted to the dim lighting. Doing this adaptation allows the eyes to better see the contrast between the black and white checkers and allows the VEP to be better formed. Monocular stimulation, that means stimulation of each eye, is best and is needed to answer the question of optic nerve function. And so binocular stimulation for a pattern reversal VEP is not as useful as monocular stimulation. For the flash VEP, The stimulator is typically a grid of LEDs built into goggles, as you'll see in the picture, or a photostimulator lamp could be used. The stimulation rate is typically 2 per second, and one eye or both eyes can be stimulated, and the eyes can be open or closed. The pattern reversal VEP is typically presented on a monitor that's placed in front of the patient. As I previously mentioned, we usually look at monocular pattern VEP recordings if possible, if the patient is cooperative for that. The luminance, that is the brightness of the stimulation, as well as the contrast, the brightness between the black and white checkerboards, must be known and standardized. And so this is something that medical engineering should standardly do, is confirm the monitor has the right luminance and contrast. The reversal rate of the checkerboard between the black and whites is typically at about 1 to 2 reversals per second. The patients must sit more than 70 centimeters away from the screen so that the checkerboard activates just the foveal part of the eye. But the actual distance that the patient sits is standardized within a lab, and for our lab, the patient sits 1 meter from the screen. Now the check size must also be standardized, and so for a full field recording, the check size is 28 to 31 minutes wide. The whole field size, that is the entire space of the monitor, must be 8 degrees for a full field and 10 to 16 degrees for a hemi-field. The type of monitor being used is very important because different monitors will have different contrast and luminance, and so new monitors must be tested to confirm that they generate the same latencies for the VEPs as the old monitors where the norms were created. And so if a new monitor is purchased, then ideally a couple of volunteers come and they're tested on the new monitor and the old monitor, and their VEPs compare to ensure that they give the same latencies. The montage for the flash VEP is simple and consists of only 2 electrodes. OZ is the active electrode and is referenced to a frontal midline electrode, typically FZ. As the kids, we also place a rudimentary ERG on the patient to confirm activation of the retina. And this is done by placing the electrode on the skin underneath the eye and referencing that to FZ. The montage for the pattern reversal VEP typically consists of 4 electrodes. The reference electrode is a midline frontal electrode, and there are 3 to 5 electrodes along the back of the head. In an adult pattern reversal VEP, the electrode placement is typically according to the Queen-squared method, where the midline frontal electrode is located 12 centimeters above the Nasion at midline. The mid-occipital electrode is located 5 centimeters above the inion at the midline, and then the left and right occipital electrodes are located 5 centimeters to the left and right of the mid-occipital electrode. Now in child recordings where the head might be smaller and 5 centimeters would be quite far away from the midline electrode, the 10-20 system might be preferable. In this case, the reference electrode would be FZ, the midline electrode at the back would be OZ, and then O1 and O2 would be the left and right lateral electrodes respectively. When doing a hemi-field recording, 2 additional electrodes are added at the back, and these are the left and right temporal electrodes, and they are located 5 centimeters to the left and right of the left and right occipital electrodes. And so along the back, one would have the left temporal, and then 5 centimeters over the left occipital, 5 centimeters over the midline occipital, 5 centimeters over the right occipital, and then 5 centimeters over from that would be the right temporal electrode. And this is for hemi-field recordings. The recording parameters for the flash VEP are as follows. In adults and children, the stimulus rate is 2 per second. Infants can also be tested at 2 per second, or if a good response is not seen, the stimulus rate could be slowed down in an infant. The stimulus rate needs to be slowed down in a preterm infant and is typically at half per second or 1 stimulus every 2 seconds. The sweep length or analysis time in an adult is 250 milliseconds. In children, it's lengthened to 500 milliseconds. In infants and preterm infants, it's lengthened to 1 second, as the P100, the typical response, is quite late. The number of trials required in an adult is 100 to 250 trials. In children, infants, and preterm infants, because the skull is thinner, the visually evoked response is actually larger. And so for this reason, fewer trials are needed. And so 50 to 60 trials is often sufficient for getting a good VEP. The bandpass for all age groups is 1 to 200 hertz, so a low-pass filter of 200 hertz and a high-pass filter of 1 hertz. These are the recording parameters for the pattern reversal VEP, and they're quite similar between children and adults. The stim rate for both children and adults is 2 per second. The sweep rate is a little bit longer in children because their responses could be a little bit later than in the adult. So the sweep rate for an adult is 250 milliseconds, whereas it's lengthened to 300 to 500 milliseconds in children. The standard number of trials recorded, according to the guidelines in adults, is between 100 to 250, whereas again, fewer responses can be recorded in children because they generate larger evoked potentials. The bandpass is approximately the same. The high-pass filter in an adult can be between 0.2 to 1 hertz, and the low-pass filter can be set at between 200 to 300 hertz. It's very important to replicate responses, especially if one is looking at demyelinating conditions where delayed latencies are what we look for. And so replication is defined as having two responses where the P100 latency is within 2.5 milliseconds of each other between the two responses, and the peak-to-peak amplitude of the N70 and P100 is within 15% of each other. The typical VEP in an adult is a triphasic wave consisting of three components: the N75, P100, and N145. The VEP is typically shown as positive up in the guidelines, and so the P100 is a positive going, upward going waveform at about 100 milliseconds. In our populations, in children, the flash VEP is typically larger and a little bit earlier than what is seen in adults, and so we call our components an N70 with the same P100. And the N70 is a little bit earlier than what we see in adults, but the P100 is at about 100 milliseconds. In our child flash VEP recordings, we will also see an ERG, which is the lower tracing, and all we're looking for is a deflection that reflects the activation of the retina. This is an image taken from a textbook of a typical pattern VEP recording in an adult. And so you'll see that there's a pattern reversal stimulation of the right eye, and this generates a response at the occipital electrodes, the left and right occipital electrode and the midline occipital electrode. At the midline occipital electrode, you'll see an N75 and the positive deflection denoted as the P100, and then N145. You'll also notice that the lateral electrodes, the responses are a little bit smaller than at the midline, and this is very typical. These are tracings from our lab of a pattern reversal VEP completed in a child. You'll notice that the recording electrodes are done using the 1020 method because their heads are smaller, so there's an OZ, O2, and O1 recording. And then there's a left eye, a right eye, and a binocular recording. In each of these recordings, you'll note that there's a deflection that goes downwards, that's the N70, and then a positive going deflection, that's the P100.